Okay, guys. Well, welcome. Like always, thank you for spending your evening with us. Hopefully, you'll enjoy this talk and get something out of it. I'm gonna try to make this particular talk a little more interactive. We're gonna have some videos we're gonna look at. We're gonna really talk about a whole bunch of different little topics that we're gonna navigate through. This is actually a second part to my CE last year. So last year I tried something a little bit different, and I talked about the Veterinary Cancer Society meeting that I go to every year, which is where we really sit down as oncologists, and of course we'll talk a little bit about the Cancer Society here in just a minute, but we really talk about new things that are coming onto the scene, as well as future research and directions that we're putting our efforts, and really try to bring out some new information that you may not know about, or certainly that may not actually be published for the next few years. And I think it just gives you a little something new versus just repeating and really rehashing some of the old topics over and over. If you are ever interested in the Veterinary Cancer Society, please go check it out, veterinarycancersociety.org. General practitioners are more than welcome to be a part of this group. It is a great group to be a part of. So it's a non-profit educational organization. There's about 1,000 people, 1,000 specialists, that is, that are a part of it: medical, surgical, and radiation oncologists, surgeons, internists, pathologists, pharmacologists, and like I said, general practitioners, residents, interns, technicians. The Veterinary Cancer Society has a great technician meeting that goes along with its conference for veterinarians. So it's a good meeting. I will say there are a large part of the Veterinary Cancer Society meeting that is it's a little bit detailed. Even for me, you can get a little bit glassy-eyed listening to some of the benchtop research and some of the molecular biology. But there's also some really good topics that come out about some of the clinical medicine, and that's what we're really going to talk the most about. But the goal with this meeting, when we go to the Veterinary Cancer Society, is to put everybody in one room and really start to talk about some of the directions and some of the concerns and some of the efforts that everyone's putting out, and really allow us to share information and continue the fight against cancer. So I'm going to hit on some of the topics and some of the highlights from the meeting. Tonight's goals: again, some of the new stuff. We are going to bring to light new developments, some of the unpublished findings, ongoing work in the discipline of oncology, as well as try to provide a platform for everyone to talk about some things and look at some questions and discuss some different topics. There's 2 or 3 things I'm going to try to hit on, and this is just hopefully we can get through some of these things. As an outline, we're going to talk about a new treatment for lymphoma that some of you may or may not have heard about. I am really starting to offer this treatment now. Certainly haven't used it much, but I want you to know about it. We're going to talk about something we haven't talked about in a long time here, or really I don't know if I've ever talked about it in this meeting, and that is radiation therapy. So radiation therapy, as you know, is not necessarily available here in Nashville, but we do work with a group south of here that does radiation, and certainly it's something that we still have and that we still recommend, and it's certainly a tool in our toolbox. And I want to get you guys up to date on what's happening with radiation therapy, because it may be something that you've kind of checked off and said, hey, that's not available here in town, so it's not for my clients, but it certainly is becoming more affordable, more safe, and more effective every day. We're going to talk about some mast cell tumor info, because it's just super common, and you see mast cells all the time. And then I'm going to talk a little bit about sarcomas. Now, I picked this out of a bunch of different ones because I get this question actually fairly frequently, and that is, we get a diagnosis of a splintic hemangiosarcoma versus a splintic stromalsarcoma, and some people didn't really know or don't really know the difference between those 2 types of tumors, but there actually is a couple different types of sarcomas you can get in your spleen, and they're not equivocal. The other thing is a new diagnostic tool that I think is just cool, and I think is something that you might be thinking about to put in your hospital, because I'm thinking about it for here. And the next one, or the very last one we're going to end with, is a real fun topic called the USP 800. And some of you may know what this is, some of you may not, but you all need to know by December 31st. So we'll talk about that at the end. Okay, so we hit on canine lymphoma, blow through a couple slides here. This is just, kind of the general breakdown of what lymphoma is. It is a really common cancer in dogs, as you all know. So it actually makes up about 15 to 25% of all canine neoplasia. So that's a big, big, big number. To put that in perspective, if we talk about things like bladder tumors, you'll see statistics like this makes up 2% of all canine neoplasia. So lymphoma is a big one. And it originates from any lymphoid tissue, lymph nodes, spleen, bone marrow, thymus. And it's also considered in dogs to be a systemic disease. There are localized forms of it, but certainly in general, this is a systemic disease. And what does that mean? It means we typically treat it with chemotherapy or with medication. The typical chemotherapy treatment that most of us will talk about as our first-line treatment is CHOP or University of Wisconsin-Madison. University of Wisconsin-Madison protocol is a CHOP protocol. CHOP just means it includes these 4 drugs: cyclophosphamide, doxorubicin, vincristine, and prednisone. Those are considered your gold standard core drugs. They're considered the most effective with the highest response rate and typically carries the longest and best control, particularly for B-cell lymphomas. Also considered very effective for T-cell lymphomas, but that is usually going to be the first-line therapy that most oncologists and most veterinarians talk about. Second-line treatment means this patient went through treatment and he lost his remission, or she lost her remission. Lymph nodes got big again. We came back in and said, what do we do? Historically, we as a group, or most of us, have gravitated towards CCNU or lomustine. And lomustine has just been a very economical, very easy, very straightforward protocol, and it carries a pretty good response rate. So we see a lot of dogs that will respond to this treatment course and get back in remission. It also is considered a really, really good drug, just as a side note, for some variations of lymphoma such as cutaneous or epitheliotropic lymphoma. We really like it for that disease because of the absorption it gets into the skin. But it's not considered a real optimal first-line therapy. The reason is because you're just basically putting all your eggs in one basket. You're coming in with a single drug, you're putting all your effort into that drug, and so resistance becomes an issue when you're using one drug only. And so is a second-line treatment good? Is a first-line treatment not great? The typical prognosis that we're giving clients when we do these protocols, and I put the yellow there because that's your B cells and then the others your T cells, but we'll talk about a 90% response rate with B-cell lymphoma that's treated with CHOP with a duration of about 12 months, or median survival time at least of 12 months. You're going to have about 20-25% of cases that are going to go 2 years or more. And that just kind of gives you a little bit of a foundation when clients say, is there any chance my dog could go over 2 years? And it's like, yeah, you got about 1 in 4 chance. The rescue treatment, and so these numbers aren't bad, but when you get to the rescue treatments, they're not very great. I mean, they're really not as attractive as you'd like them to be. You start talking about response rate of 40%, 60%. 60% is kind of pushing it. I mean, you need to be using some pretty good protocols if you're going to get to 60% for a rescue. Rescues are typically 40% for about 2 or 3 months at the most. I mean, 1.5 to 2.5 months is what most of the real papers and publications will quote for lomustine, for MOP, for some of these protocols that we use as rescues. So that's really where we hit hit kind of a wall with lymphoma. Great response rate is your virgin initial treatment. Great duration the first time out the gate. Struggle with our rescues, and that's really where we've been. The new drug that's going to be coming out that you guys are going to be hearing about, that's on the market right now, that a lot of us are gravitating towards, is a drug called ToxinVia. And ToxinVia CA1 is a new chemotherapy drug for lymphoma. This is one of I guess you would say this is one of the first times that we've actually had a new true chemotherapy agent that has hit the market and really has started to live up to what people have talked about. It's a little bit of a different drug. It's given, and we'll talk about that, like most traditional chemotherapies, but this is a traditional chemotherapy drug in the fact that it is a cytotoxic drug. It's an inhibitor of DNA synthesis. The way it works is it inhibits DNA polymerase, which is needed for DNA replication, and it causes apoptosis of lymphocytes, malignant lymphocytes particularly. This is their website, so if you ever go to it, you can Google it and come and bring it right up, but this is So the drug basically goes inactive, becomes activated once it's in the body, and then it gets incorporated into DNA synthesis. And it's going to basically, as you go through this, it's going to cause a block of that completion of synthesis, and then the cells will go into apoptosis and die. The absorption rate for it is extremely high. And then if we start to look at these guys, when you start comparing it, it's pretty. The drug, when it first hit the market, people really didn't know if it would have a nice target into lymphocytes to be able to determine malignant versus non-malignant, and it really does. I mean, the reason for that is these lymphoblasts, particularly these B-cell lymphocytes, they are producing at an incredibly fast rate. So when you go in and you give this drug, it will get absorbed in some of the normal cells, but because of the rate of replication is so much different between malignant lymphoblasts versus normal lymphocytes, you see an overwhelming absorption into the malignant cells. And so the long and short of this is that we give it as a 30-minute infusion every 3 weeks, like a lot of chemotherapy drugs that we talk about. But during that time frame, you're just going to have a significant amount of absorption into your malignant cells. If everything's going the way we want, we usually do about 5 total treatments. So very similar to if we were given a doxorubicin or a carboplatin, mitoxantrone, that 30-minute infusion once every 3 weeks. At the last VCS meeting, veterinary cancer study meeting, we did look at data, and remember what we talked about with the response rate being 40%, 1.5 to 2.5 months. ToxinVia is being used, and it's kind of, this was the title, but I'll kind of explain. A first-line rescue just means that was a rescue course. That was the first rescue they used. So that was their second-line therapy. B-cell lymphoma, treated with 5 doses of ToxinVia. Their response rate was 77% at a 45% clinical remission, and the progression-free interval for the CRs was 215 days on a rescue. That's huge. Those dogs are getting out like 8 months on their rescue or more. When we start to look at just the general numbers, 5-6 months, that's so much better than what we're seeing at 1.5, 2.5 months. So this was not in a small group of dogs either. This was in a really diverse protocol over multiple institutions, and certainly when I look at these statistics, this was a real push for me to bring this in here and start using this drug, because that response rate is just something we're just not seeing with our rescue courses. So ToxinVia does have some drawbacks. One is just managing adverse events. It's a new drug. You're going to hit some hurdles, because you're going to see some things that certainly you may or may not have dealt with. One of the weird ones with this drug is it actually can cause a dermatopathy. So you can actually get a fairly pretty, and this is very self-limiting. Once you got the drug out of the system, they did well, but they definitely can get a pretty significant erythema. Just certainly it's not even really a dermatitis. It's more of an allergic reaction is what it is. But the body kind of took a while to clear it from the system, and once they did, that dermatopathy would resolve. But some of the patients did lose a lot of hair. They even got some areas of ulceration on their skin from it. So it was a limited number, pretty small number, but it's one of those things as you start to bring these new drugs in, you got to kind of talk through, like, there's some stuff we just don't know about it, but there's a lot of positives we do know about it. The neutropenia, the diarrhea, the lethargy, anorexia, I mean, these are all things that we see with a lot of drugs. They're still self-limiting. They were all grade 1, grade 2 toxicities, which are pretty much what we'd anticipate with lomustine or any of the other rescues. The dermatopathy was the weird one. Probably the question everybody wants to know is, like, what's something like that cost? Is that a real expensive drug? Is it not a real expensive drug? It is a costly drug. It's not a crazy costly drug. If we look at how it compares, it's probably about $400 when you do a treatment. And so if you're doing 5 of them, you're probably, and that's catheter and chemo administration, your exam, all that stuff. So I mean, as a rescue, you can get $2,000 into something like this over a 4.5 month period of time. 4 month, 4.5 period of time. So it's more than our lomustine, but it's actually going to be probably not as much as some of the other multi-drug rescues, and none of them are getting that kind of number. So if we're getting close to those numbers, then that's a reasonable protocol, and that's going to be a pretty. I think they've set this thing at about the right cost level where it can be used, because I do think they're wanting us to use this. So ToxinVia. Vet DC is what it's called. That is actually it's actually a Lanco is who owns it, if everybody is looking at that. So Vet DC is a Lanco. That's who bought that group and bought that drug. So they're the ones that are putting it out there. They're trying to market this. I mean, these are the first times in our career, in our history, we're actually seeing these FDA drugs brought to market pretty fast and getting put out there and getting to use. And certainly they're looking for response. They want people to use it. So good drug. I'm excited about it. I'm excited about what it potentially could mean for dogs. I'm going to go through this one quick because I talked about it last year, but this is, and I kind of faked a picture here because that's actually a melanoma vaccine, but it looks the same. So the box looks the same, and the tool we use looks the same. But this is the immunotherapy treatment for lymphoma. This is actually not a true treatment, but it is used to be an immune stimulant to help hold remission. ToxinVia is a cytotoxic drug to get you in remission. This is meant to help you stay in remission. So the lymphoma vaccine has been out for a couple years now. It is commercially available. We have used it in several dogs. I'll talk about my experience in just a minute with it, but it is meant for B-cell lymphoma dogs only. These dogs have to have immunophenotyping. We have to know if they're B or T. If we don't, this just doesn't do much because it heightens the immune system to look for B-cell lymphoma. If you have T, you won't hurt them, but you're not going to do them any benefit. It's 4 transdermal injections. You give an injection once every 2 weeks, and there's really no significant side effects. I've used it in several, and there's just really not any side effects. I'm not going to go into a bunch of detail how it works because we talked about that before. It is coding the immune system to look for canine CD20, leading to the destruction of neoplastic B cells with CD20. So it's producing antibodies to attack the marker CD20. So your immune system is going to look for that and try to remove it from the system. It's a passive immunity. It's not killing them themselves. It's tagging and allowing the immune system to then clear those cells. So that's what passive is meaning there. The vaccine, as you kind of read here, and I'll let you guys look through it because I want to go on to some other topics, but it was formulated off of the melanoma vaccine. This same technology has been out for many years with the melanoma vaccine, so it's very similar. This has also been in the human field for a little while, so CD20 vaccine have been utilized in non-Hodgkin's lymphoma in people and proven effective for several years. Non-Hodgkin's lymphoma is what we see in our dogs. That means it's just multicentric. The pilot studies that were done showed safety, showed a very high safe profile, and really no significant adverse events. It is not, I will say, considered to be a standalone treatment. You do not take a dog with lymphoma, give them that vaccine, and expect them to go in remission. You won't see anything probably. What it was meant to do is once these dogs are in remission, they've got microscopic disease, it's then meant to heighten your immune system to try to keep those cells suppressed if they are still remaining in the body. Example I would give you is if you got full-blown flu, don't go to Walgreens and get a flu shot. You're not going to get any benefit at that point. But if you want to heighten your immune system to try to suppress that at low levels, it could work. So not a standalone treatment. And I do get calls where clients don't want to do chemo, they just want this vaccine. And I'm like, I won't give it to you. I mean, it's just not, you're wasting the expense of doing it. So CHOP-based protocol in combination with the lymphoma vaccine yielded approximately or greater than 734 days in the limited study. And I showed you this last time. That's a big number. That's a big, bold statement for somebody to come out and say, because historically we see those numbers at the bottom. We see about 25% go in 730 days, not over 50%. So what was the catch and what continues to be the catch? When they brought this drug to market, when Mario brought it to market, it was a very small protocol. Very small power group, very small number in the study. 10 dogs. 10 dogs is what they treated. 10 dogs, big numbers, everybody got excited, and then they stopped. They didn't do any more research. So there's still groups out there right now collecting more and more and more of these patients to try to put a study out to say, is 730 real, or were those 10 dogs just lucky? And that, that does happen. So the power was weak on that, and so that was the main limitation. Is that to date it's the power, the low power due to limited number of cases. I think just my experience with it, I have used it in several dogs. I'm just going to be 100% honest with you. It's super safe. I have not had any patients have any issues with it. I have had mixed responses. I've had dogs that have stayed in remission and have went on and done well the last couple years, and I'm thinking, great, I hope that's the vaccine. And then I've had dogs I've given to, and they've come out of remission just like they would if I hadn't have given it to them. So are those dogs that stayed in remission, are they the 25% that might have done it anyway? Are the dogs that came out, were they just a bad case? It's hard to say. So I think we just need it, to do it, use it longer. The negative with it is a costly one. I mean, that vaccine is given right on the heels of CHOP, and it's about $2,700 when you do the 4 shots. So you come off a pretty big protocol and you go on to that. I need to be able to tell clients like, hey, this is going to get you 2 years if you do this. And I don't know if I can do that yet, but I do think there's a subset out there of people who say, you know what, I want to do everything I can. This is safe. It's not going to hurt my pet. And there is some data out there saying that it could be beneficial. I want to try it. And that's who's using it right now. So we don't do it in every dog. I'm not sitting there pushing everybody to do it in every dog. I'm telling them it exists. I'm telling them it's out there. They do some research themselves. And I'm saying, the biggest drawback is not you're going to get sick, not there's any problems. It's real quick and easy. It's just the expense of doing it. If you're comfortable with the expense, then there's certainly not a lot of drawbacks other than just the really unknown expectations. Again, I pushed through that just because I really wanted to kind of just bring it back out, let people know if you have those clients that are saying, is there anything else I can be doing? That does exist. And then the ToxinVia obviously is the big one we're going to be talking about in the future. Okay, so last little bit on lymphoma. T-cell lymphoma is a big one. T-cell lymphoma is a tough disease. This was at the VCS meeting this last year. I kind of wanted to bring it up. Again, it was only 35 dogs, but it was some pretty impressive results. They showed a study here called LOP. I've used this protocol a couple times. It is kind of a beefed up version of your lomustine, but this is a first-line treatment. So they're actually coming in. When I said, what's the negative with lomustine? Well, you're putting all your eggs in one basket. This is where they're taking lomustine and say, well, that works really well against some T-cell lymphomas. Let's add a bunch of other drugs to it and make it like a CHOP and see what we can do with T cells. So lomustine, vincristine, prednisone, and procarbazine. So basically what they did is procarbazine is in the same family as cyclophosphamide, so the Cytoxan. They pulled the Cytoxan, put procarbazine in, and they pulled the doxorubicin and put lomustine in, and we call it LOP instead of CHOP because we're real creative like that. And so we ended up with this as a first-line treatment course. So these were T-cell lymphoma dogs. They ended up with a median survival time of 509 days, and pretty much everybody in the room when they said that was like, what? How'd you do that? And so they did it because 73% of them got pretty sick. But they pushed these dogs pretty hard with these drugs, pretty high levels. They got a good response. I think this protocol is really good for T-cell lymphomas. I think we're finally finding that not every dog with lymphoma fits into a protocol of CHOP only. I think we're really looking at saying we need to tailor these protocols to dogs. If he's a dog that can handle a higher protocol, a little more intensity, if he's a dog that's got T-cell lymphoma and the owners are open to it, I am bringing this up and saying like, hey, you got T-cell lymphoma. Let's start talking about maybe changing your protocol because we've got some drugs that might work a little bit better, instead of just saying I'm going to run every dog with lymphoma with CHOP. That is something that I think historically, even as oncologists, we've done. We've just saying let's just treat them with CHOP, and when they come out, we'll use lomustine. Now we're really trying to tailor these. So this was a little bit of a retrospective aspect. They're doing more of a bigger prospective study. They had done this the year before. This was the year before. Again, same kind of deal. They did LOP as a first line. Same kind of deal. Overall median survival time was 323. I mean, this one was 509, so there's obviously a difference there, but it's still way better than what we were seeing. I mean, historic data with CHOP has been this 5.8 months. So, you know, you're doubling it, maybe tripling that time. So I think it's just important, you know, to bring it up is that these are probably indications to start using different protocols for different phenotypes. The next thing I want to talk about is radiation therapy. We do not have radiation therapy at Nashville Veterinary Specialists on site. That is certainly something we'd love to have in the future, but at this point in time, there is not a radiation facility in Middle Tennessee. Actually, the radiation facility at University of Tennessee, Knoxville is actually not functioning at this point either. They're actually not taking cases, and I'm not sure when they're going to take them again. Not because they don't want to, but their radiation oncologist is on maternity leave, and they're just limiting how many cases they bring in there anyway. The biggest thing is it is a tool, though. It is a tool that we all need to be thinking about. We need to know exists, and it's a tool that we can utilize. We currently work with Georgia Vet Specialists in Sandy Springs, Georgia, to offer radiation. How do we do that? We work with Dr. Nathan Lee, who's over at University of Tennessee for a long time. He's now at Georgia Vet Specialists, and he will do phone consultations for clients. They don't have to drive all the way down. Their consult's covered. If they come here and see me, their consult with him is covered in my expense. So that means they can get a radiation consult, no charge, if they come here and chat with me first. And even if they don't, then we can still talk to him. He'll be happy to help you guys out. They do offer all options when it comes to radiation therapy. They have a brand new machine they put in this summer there. They offer, and we're going to talk about it, Stereotactic radiotherapy, which is the latest and greatest. Obviously, your traditional external beam definitive radiations, as well as palliative radiation courses. And so certainly when it comes to options and it comes to what they offer, they have everything at that facility, and it's a great facility. The biggest thing about it, and the reason I like working with Dr. Lee on this is, I mean, he sets your clients up so when they get there day one, they're not driving back and forth. They're there. They're ready to get treated that day. Everything's set up. If they come here and we do a CT scan, he can see the CT scan on my computer. He can get these guys set up so when they roll in day one, they're ready to be treated. As a side note, he also will work with them and not charge them boarding. And so that's huge. So that means that dogs can go down there, and if they're going to be there for a couple weeks, they're not getting charged for boarding. That's covered in their radiation costs. So I would definitely be recommending them for radiation. They've done a great job, and I've got great feedback from all the clients that I've set down. It's something that we want to use. It's something every oncologist needs to have, or at least have access to. And at the current time, I think we've got a pretty good setup with being able to offer at least that information, options for your clients. Yes, it's a drive, but it's as good as it's going to get, certainly unless you have one sitting right here. I mean, and he's doing a good job for us. So we're going to go through this. Like I said, locally, what are we offering? Well, we do consultations on RT therapy. I'm comfortable with talking to it. We can do CT planning here. We use thermoplastic masks, which are these really cool fancy things you see up there on that golden retriever that basically allow them to conform to the head. That snaps to the table. If I do that here, if they take it with them to Georgia, they snap it down. The dog lays in the exact same position as he did when he did it on my machine. So that's the nice thing about the mask. Follow-up appointments or rechecks can all be done here. So they go down and get radiation, and I can see them and do their follow-up appointments. And if there's an issue, we can send pictures and stuff to Dr. Lee and work through that. So you're not dealing with side effects at your clinic. Thermoplastic mask, again, just allows for a real nice conformation. It allows for consistency. That's really what it is for. It allows you to do multiple treatments on multiple days and make sure you're hitting the exact same area every single time, which is really nice. So what's new? I thought this was really cool. We talked about this at the Veterinary Cancer Society. On this side of the screen, underneath over the hand, is what we used to do for what we call bolas. And first thing is, this type of bolus has the coolest name. It's called Superflab. And so Superflab is what we've used forever. And Superflab is a fake skin. And what the idea behind Superflab is that you can put it over an area, and try to distribute out the dose of radiation. Think about radiation being like a light you're shining on something, a flashlight you're shining down. If you've got this really curved surface, you're going to get a lot of light right here in the center, and then it's going to taper off as it goes off the side. So superflab would be, they'd lay it on this side, and they'd lay it on this side and try to build it up, make it somewhat even so your light would be more evenly distributed. That's so you don't get hot areas, as you can imagine, as you're delivering radiation. Now we have 3D printers, and 3D printers can actually make 3D printed bolus instead of superflab, and it improves your dose distribution. So it equally distributes that radiation dose, and you do it in these really kind of asymmetrical, very kind of as you can see, like a face, non-level areas of the body. And so, as you can see there, the idea behind it is that will allow that to be more conformed, especially over non-smooth areas. There was a study that was done, they compared them. The maximum gap that you would see when you put that flab over it also is it kind of lays over it like a blanket. There'd be these pretty big areas of air between the flab. And so it was 2.2 millimeters though when you did a printed bolus, is almost double that with superflab. And then it markedly improved your virtual dose in areas on high irregularity. So you were, what your computer said you wanted and what you could create with the patient was really close, because it says you want this much here and this much here, and you can actually make that with bolus. I mean, this is just something that I think is neat, because it just tells us like where and how much is possible with technology these days. Who thought a couple years ago that you could buy a 3D printer, sit in your house and hit the button and print something like that out? And you can, and it's really economical. It's not a very costly thing now for them to do. So most of the guys are going to these 3D printers. They can use CTs and make it a flat area and radiate it. The reason I bring that up is because one of the things that your clients will ask you when you talk about radiation is, well, I remember when I was a kid, everybody talk about radiation burns and having side effects and all these issues. I mean, that's the kind of stuff that we're getting away from, and we're able to now do these treatments with very few side effects. Stereotactic radiation therapy is certainly the latest and greatest in terms of delivering the radiation. Now, stereotactic is true definitive radiation. I had someone ask me the other day, well, how much radiation do you give for a mast cell tumor? How much radiation do you give for a soft tissue sarcoma? When we radiate patients, we treat them to your normal tissue tolerance. So wherever you have your tumor, whether you're a person or a dog, we don't tailor it to what it takes to kill the tumor. We say, how much radiation can I put in that area before your normal tissue starts to say stop? And so that is what definitive radiation means. When somebody says it's 50 gray, that's what we're going to give you for a mast cell tumor. It's not because that's what we think is going to kill a mast cell tumor. That's what we can get away with where you start to have an issue. And so normal tissue tolerance. To achieve normal tissue tolerance, to get that much in there, we've usually had to break it up and do what's called fractions. And so fractions means that you are getting, as you guys know some of this, if you get it Monday, Tuesday, Wednesday, Thursday, Friday, Monday, Tuesday, do it for multiple days. I use this analogy with my clients all the time. I always tell them it's kind of weird, I'm going to say this, but if you're wanting to get a tan and lay in the tanning bed, you don't go in there and crank it up for 3 hours and say, I'll see you in 3 hours. You do 15 minutes for multiple days, and that way you don't burn yourself. So same kind of thing. We do that, and that allows your normal tissue to heal, and we can build that up there until we reach and go, okay, any more and we might have an issue. Well, Stereotactic uses a technology that is more pinpoint accurate. As you can see in the one over there on the side, it's a robotic arm that allows them to take that and really just almost carve that tumor out as they're delivering that high dose of radiation versus shining that flashlight down over the whole patient. So in simplistic forms, you can deliver a whole bunch of radiation in a really short time period. So you can deliver that pinpoint accurate, not affecting the normal tissue because you're not hitting the normal tissue, so you're not worried about the normal tissue tolerance in that, and you can do it in 1 or 2 treatments. So to repeat that again, if you have a nasal tumor, instead of me giving you 20 treatments over 4 weeks, you can go down, see Nathan, he'll give you a treatment on Monday, maybe one on Tuesday, and you're done. You get your 2 treatments. So stereotactic radiotherapy, SRT, as you see there, multiple beams at a variety of angles. That allows you to hit that thing from different areas. receive a high dose of radiation, and the tissues around it only receive a low dose, because you're pinpointing it on only hitting the tumor. You're really conforming it to the tumor. Lowers the risk of side effects because you're not hitting all that normal tissue. It allows you to deliver a full dose in a very limited number of treatments. 1 to 3 is what we give. I mean, 1 to 3 treatments. You know, that's unheard of. When I went to vet school, we talked about radiation, 22 treatments. Patients were there for a month. Now we've got the technology, we can do it in 1 to 3 treatments. So I'm bringing all this stuff up because most people, when I'm talking about radiation, they're like, what? I didn't know that happened. So or you could get away with that, or you could do that. So that is a big, big deal. Not everything can be treated with stereotactic, though. If you have a soft tissue sarcoma or a mast cell tumor that we removed and we didn't get it all, and we say, you know what, I really want to do radiation, and you've just got this scar on the leg, well, that's kind of tricky to go, up and down your leg. So because you're really treating how it fades out into it, where any of those fingers can be. And if you can't see the fingers, if they're not showing up, you really can't do that. So that's kind of area where the light is better. So those are the ones you have to do, really steal the definitive, at least at this point. But brain tumors, nasal tumors, you've got that CT, you're looking at the tumor, you can peel that thing out of there. A bone tumor that's sitting next to the spine, spinal cord tumors, and even bone metastasis, that's what they're using it for in people right now. These are options, especially the ones we're hitting on now is the brains and nasals. I mean, those are the ones we're really talking about stereotactic with. Stereotactic radiation therapy for nasal tumors, does it work? Well, here's a study, and there's a lot of these out there. 18 dogs, nasal adenocarcinoma. This was recently published. 1 to 3 fractions, and you saw improvement of 17 of the 18 cases that were treated. Progression-free interval was 454 days, and survival time, you can see there, was like almost 949 days. So these dogs are definitely responding well. And certainly these numbers get a little bit high when you get into the survival time. But I will tell you, what I usually tell clients is this is equivocal to what we were achieving with definitive 20 fractions. I mean, I wouldn't say it's necessarily absolutely better, but it's certainly easier when you do 1 to 3 treatments. Toxicity was noted in 11 to 18 acute ones. That's going to be kind of your irritation or maybe some discharge you can see there. The fistulas, the blindness, the seizures, KCS, that kind of thing. We have had a case here a couple years ago where we had a late-term effect about a year later where some tissue died off over the nose, and Dr. Roach had to go in and do a flap of skin because that bone died. So it is a big dose of radiation. You're dumping some serious radiation, and there is a risk that when you do that in a real focal area that you could kill that bone. And had to take that bone out and bring a graft of skin over it because that bone died. But that dog was a year out when that bone finally died. So those kind of things are there, and they're possible. These are not unusual side effects. These are the side effects that are reported. They're rare, but they're reported with even the definitive. So I mean, I think it's safe. I think it's a great option. I think if you're traveling from Nashville to Georgia and you only got to go for 1 day and you get your full treatment, it's a really great option. So what's it cost? That's the deal. So these are actually straight numbers. I actually talked to Dr. Lee, had him give me some direct quotes. These numbers used to be a lot higher a couple years ago. So this kind of just gives you an idea how some of this has reduced and changed. Stereotactic, when it first came out, I mean, there's clients that were paying like $10,000, $12,000 to get it done. Now it's about the same price as your 16 to 22 treatments because these guys aren't getting treated every day. They realize, well, I only got to do it 1 to 3 times, and multiple people are doing it. So they're charging pretty much equivocal. If you're a candidate for stereotactic, you get stereotactic. If you're not, then you can get the other. You still get the other, but the prices are very, very similar. Your CT planning can be around $1,000. Your $5,000 to $5,500 for stereotactic or definitive, that's going to be pretty much what we're seeing with that for full course treatment. Palliative treatment means that we're putting 4 to 6 doses. We're not reaching anywhere near what we're doing dose of radiation. Those are big tumors. You got a sarcoma on the leg that's not operable. We just want to try to shrink it down, maybe make the dog a little more comfortable for a while. That can be done once a week for 4 weeks or 6 weeks or over a period of a couple weeks. That's about $2,500, and again, that's all meant to make those patients more comfortable and help them. The dual shot 10 gray for osteosarc, that is if you have a big mastiff, he can't have an amputation for some orthopedic issue or neurologic issue, and we're just trying to make him more comfortable. We can do 2 shots in 2 days for $1,800, and there's about a 75% chance that dog's going to be a lot more comfortable when he leaves. That is a good option. When you do palliative for osteosarcs, and we're putting that higher dose in there, that 2 shot like that, they use that as a $1,800 because, as you can see, the others is 4 to 6 treatments. So we can do that a little bit cheaper. But again, radiation consults are included with my consult, and there's no charge for boarding these pets when they go down to see them. So it's a plug for radiation. It's to give you an idea that it exists, and just because we're here and don't have it doesn't mean that your clients and these patients don't still have opportunity to use it if they see fit for it. Okay, so mast cell tumors, and like I said, I added this in just because they are so common and you see so many of them. This is a little bit of one on the surgical side of it, and the reason I brought it up is because I've kind of talked about some of this for a little while, and I wanted to put a topic in that came up at the Cancer Society meeting this last year. So as most of you guys know, when it comes to mast cell tumor, surgery is usually considered a first-line treatment for certainly a solitary mast cell tumor. And as we talk about surgical margins, as you see here, we talk about these lateral margins should be around 2 to 3 centimeters. A deep margin should be a fascial plane. If necessary, muscle layers should be removed. And then obviously all tumors are submitted for margins and grading to see how you did and to see what we're dealing with. One of the questions that came up, and one of the things that we talked about, and this is still kind of a loose little bit of information, but I have talked to a lot of people about using neoadjuvant prednisone or triamcinolone into these tumors to try to reduce them down in size, just try to make them more amenable to surgery. A lot of these tumors can come in and be very inflamed, and when you start them on steroids or give them inject these tumors with triamcinolone, you can get some pretty significant reduction. So the question that came up was, is this affecting our ability to grade these tumors? We know with some tumors, particularly lymphoma, when we start these guys on prednisone, it can cause the cells to be really fragile. It can affect the way they appear. It can affect certainly a lot of their characteristics. So the question was, is by doing that, does that affect any of your grading scheme? We know it makes them smaller, but is there any negative drawbacks to it? So common clinical practices, you can see, to infuse these tumors or start them on steroids. And so 11 dogs were evaluated. 10 of them had low-grade mast cell tumors. 1 of them were found to have a high-grade mast cell tumor. And all tumors in this study, again, it's not a huge number, but all tumors actually had an incisional biopsy prior to starting on steroids, and then they were given them about 10 to 14 days of prednisone, and then they went to surgery and did a wide excisional biopsy or excisional removal and submitted them for histopathology. There was no statistical difference, though, in their grading, and so mitotic index, your Ki-67, your AGNOR, these are just some of the grading profiles that we use, and certainly some of the prognostic factors that we look at did not have any negative implications when you started them on steroids. So if you are thinking about that, it does not affect prognosis, and it can certainly make your surgery go a little smoother and be a little bit more amenable. The thing that we don't know, that this didn't answer, and that certainly comes up, is you have one of these tumors, it shrinks down and gets really small. How do you measure? What's your margins look like? And that's always the question, and quite frankly, I don't know if I can tell you the answer to it. I always tell everyone, if you're going to do the steroid route, if you're going to do the injectable route, take a Sharpie, take a marker if you can, and mark that tumor where it's at before you start them on steroids, before you inject it. It at least gives you a little bit of an idea of where that tumor was, so when they come back in a week, if they haven't washed it off, you at least have an idea when you go to surgery of where your margins are there, and so you can go out hopefully a little bit more around it. It doesn't mean that those tumors or those fingers and those roots didn't pull back, but we just don't know if all those roots and those fingers pull back. So we still try to use those margins, but hopefully we're seeing some reduction in it, so when you send it in and you get it back, the margins will look a little bit better than they did if you hadn't done that steroid. Jumping straight into the Splintingsarcomas. So I brought this up just because I've had several questions over the last year about it, and then I'm sitting there in the meeting and it popped up comparing Angiosarcoma and non-angiogenic sarcoma. So the way to think about it is, if you think about the spleen, it's not a super complicated organ. It's a filter. Filter is your blood. You're going to have a lot of blood vessels within it. You're going to have a lot of immune cells that help filter that blood, and you're going to have a bunch of connective tissue that just holds everything in place. If you develop a sarcoma in your spleen, you can develop it from the angiogenic aspect of it, so the blood vessels, hence hemangiosarcoma, or you can actually develop from some of the connective tissue in the spleen, the Stromalsarcomas, and so that's all that connective tissue that holds together. For years, we always said those two are pretty much the same. You know, dog comes in, he gets surgery, comes out, they say, hey, it's hemangiosarcoma, or hey, it's a Stromalsarcoma. We haven't really talked to owners about them being that big of a difference, and clinically, we've always go, are they the same? You know, are they really the same? Stromalsarcomas really equal the same as hemangiosarcomas? Are they better prognosis, worse prognosis, same? Historically, the papers that are out have said that they were similar. They would give a prognosis with surgery alone of 4 months, whereas we jump in here with hemangiosarcs and we talk about a prognosis currently being 3 to 4 months with surgery alone and 6 to 8 months with combination splenectomy and chemotherapy. What we know is hemangiosarcomas are obviously aggressive because they have this really high vascular route, which gives you a great opportunity for cells to metastasize, and that's what makes them so aggressive, is that metastatic potential. But the question was the Stromalsarcomas the same? I'm going to stop and talk about this for a second. I forgot I had this first. So canine hemangiosarcoma, obviously being that really aggressive tumor, the first thing I was going to say is there anything new? You know, I get that question a lot about hemangiosarcomas. You guys get that diagnosis a lot. You see it and you go, it's a really aggressive diagnosis. So is there anything new that's coming out that we'll maybe be able to do more with? So this was one that was published, and it really starts to talk about VEGF. So VEGF, or vascular endothelial growth factor, as you can imagine, is a really common growth factor that is found within hemangiosarcomas. Makes total sense. Vascular endothelium, the tumors are coming from the vascular endothelium, so we know they're going to have that growth factor. So what we looked at with this was a recombinant viral vector that encodes an antibody that is supposed to attach to and delay tumor progression by inhibiting VEGF. So VEGF is elevated in patients with splenic hemangiosarcoma. We know that. It's thought to drive metastasis. It's thought to reduce survival because that VEGF keeps those cancer cells growing. They keep that tumor getting bigger and that endothelial cell replicating. So the hypothesis with this study was, could you neutralize VEGF and increase your overall survival time? They did 12 dogs with stage 2 hemangiosarcoma that underwent splenectomy. Stage 2 just basically means that these dogs did not have any pulmonary metastasis or any regional metastasis to places like your liver. Some of them did have a hemoabdomen, certainly, and some of them did have a splenic mass, but they were all confirmed via splenectomy to have hemangiosarcoma. The dogs did receive gold standard treatment with doxorubicin, and then they were randomized where some of them got a vector encoding an antibody against VEGF, and some of them just got placebo. So the patients received weekly evaluations and had blood samples that collected to measure VEGF and to measure certainly that concentration to see if it was affected between the two populations. And what we found, although it was a small sample size, was that the median survival times for dogs was about 4.5 months. And median survival time for all dogs about 4.5 months was kind of low, but then there was these weird outliers that jumped out there. 200 days, 416, 500, 661 respectively, and those were the dogs that they felt like were in this study, which is kind of weird when they presented it. They said the vector appears to be safe with no significant adverse effects, and between the patient groups it appears that it could possibly be delaying tumor progression. The reason they said that was because the 661 was actually a placebo, so it kind of shows you where those outliers are. It's a small group. The 200, the 416, and the 501, those did have the vector. So you just, when you go into these studies and you look at them, you always say, hey, there's something new. That's really exciting. But then you see these small sample sizes, and that's one of the things you got to be cautious about. So is this commercially available? No. Is it a stepping stone for maybe a new direction to go? Yes. I think it is, but certainly it was one of those that basically they talked at the end and said, we're starting a prospective study. We're putting dogs in it. If people are open after they get their treatment, they're going to get the vector, and then we'll see if it makes a difference. So I'm going to this meeting again here in a couple weeks, and we'll see if that made a difference. Back to the stromal stuff. So again, these are non-angiogenic, non-lymphoma splenic masses. coming from that stromal tissue. And you have had research that certainly looks at this and think that maybe this could be a transition from these fibrohistiocytic nodules or splenic hyperplasia. But stromal sarcomas will grow. They will get bigger. They're more than hyperplasia. When you look at them, they look like your typical soft tissue sarcomas, and they're just in the spleen. Now, again, previously we've talked about these tumors having a pretty high metastatic potential, and that the survival time in the initial studies have been 4 months. There's just not a lot of studies out there. So the studies have been pretty weak. Again, it was like that last thing I just talked about. It's just the power was never great. But when I took boards and people asked about stromal sarcomas, that's the number you quote. So when you talk to clients, that's the number that's always been quoted. Do they do better? Well, that was the theory. And so this was a bigger group. This was a retrospective analysis done out of Colorado State University, their veterinary diagnostic laboratory. They do a great job there having a database and can pull a lot of cases in a real short period. These are 53 dogs. This is a strong study they identified. 47 dogs were included, and they included all the 47 because they were the ones that had the most complete records. Splenectomy, they looked at these because a lot of these dogs did not have chemotherapy. So 9 dogs received chemotherapy in combination with splenectomy. The rest of that, out of that 47, went on and just had surgery alone. And the median survival time was 322 days. So that's huge because that's way different than 4 months, and those dogs didn't get chemo. So again, they were doing that because that first paper was really surgery alone at 4 months. So here they said, let's kind of eliminate some of the chemo dogs, and got it down here 322 days, and you had some real long survivals. Now what they did find was say, okay, well, what's the catch? You know, where's the difference here? Because that study obviously showed that some were more aggressive. They found out, and this is where these studies really get important. You don't just throw something out and say, well, my study's different than your study, so you must be wrong. You know, you really want the study to go one step forward and say, this is why I think our studies differ. I respect what you did, you respect what I did, here's why they differ. So they differed because the tumor grade and the mitotic index weren't looked at, but they did look in this. What they found was that if you have a mitotic index of less than 9 on these stromal sarcomas, they consider those low-grade sarcomas, and typically they can be treated from surgery alone. I learned something when I read this, and that's why I brought it up, because I didn't know that. And so chemotherapy is likely indicated, however, for the high-grade stromal sarcomas. So if we get one here, if I get one here, that's the kind of stuff I'm looking for, is I'm looking to say, okay, is that a low-grade sarcoma? Is that a high-grade sarcoma? And are they equivocal? And in this study, and certainly my thinking now is they're not. My thinking now is if you get a splenic sarcoma that's low-grade like this, it's non-hemangio, it's got a mitotic index of less than 9, you can start talking to owners that surgery alone might be reasonable here, and that there's some survival times that could be prolonged. If it's higher than that, high mitotic index or a hemangio, then we need to be talking about chemotherapy. So it was just a new study. It was something that had not been published before, and it was something that really was different than what we had talked about in the past. This is a new diagnostic option, and so this is kind of interesting because I'm putting it in here as just kind of something I think is neat, something to talk to you guys about. You're obviously looking for stuff for your hospitals all the time that might bring something, you know, that's new. This is a group called Lacuna Diagnostics. Has anybody ever heard of these guys? Nope. Okay. So Lacuna Diagnostics have 2 options. They have something called Lacuna Autoscan and something called Lacuna Snapshot. And what these are is they're in-house cytology with a pathologist review. They have a 1-hour turnaround time, and they have about a team of 15 pathologists that will interpret your slides. They include their personal phone number, which is kind of random. I saw that when I watched their video. I'll show you here in a minute. With a report enabling for easier further dialogue. Like if you look at the report and go, what are you talking about? You can call them up, just like your pathologists do at the, when you send it in. The cost of the slides, the first site's about $80. The second site's $75, third site's $70, so forth and so on. Pathology review of a CBC is about $30. So if you do a slide smear and you're like, is that leukemia? What is that? Then you can scan the slide and send it in for $30. Their equipment that they bring in your hospital is free of charge, which you're supposed to do 20 slides per month. And that can be, you got to think about it. You got to kind of probably take a couple months and go, am I doing that or not? We definitely would do 20 slides probably in a month, but again, I was having to think about it too. It's like, how many do I send in? Is that 20? Now, the thing about it is, though, you probably would do more if they were sitting there. But the idea here is that this is This will probably get cheaper. I would definitely tell y'all to be watching this, because this is where it's going. These guys are kind of taking out the big laboratory idea and really getting into like some of this computer technology and allowing us to bring some of this stuff right into the hospital. Scan your slides, get your report, get it in an hour. It's no different than if you had a radiology review on radiographs.
We at Lacuna Diagnostics understand that time is trauma. Lacuna Diagnostics offers rapid turnaround times on cytology samples, so you can inform your clients and move forward with treatment. The Lacuna Autoscan system includes a patient-side whole slide scanner that automatically creates a digital image of your cytology samples.
Hi, I'm Dr. Eric Fish, Chief Medical Officer for Lacuna Diagnostics. Thank you for your interest in digital cytology. When you submit a case to Lacuna, it's uploaded to our cloud platform that allows our pathologists across the world to bring you answers 24 hours a day, 7 days a week. We're proud of our responsive and committed group of pathologists that would love to help you work through a case. Our phone numbers and emails are on every report, and you can chat with our team live in real time through our website. You can treat with confidence, knowing that our slides are easily shared across our network, bringing you the expertise of a dozen pathologists instead of just one.
The Lacuna system includes an automated whole slide scanner, computer, and personalized online portal for case submission. Submitting a slide is simple. Place your stained slide into the cassette and insert it into the scanner. An overview image of the slide is created, and then a scan is initiated. While a scan is being created, open your online portal and create a case. Add your slide to the case and hit submit. Once submitted, your case will go to the cloud and one of our pathologists will grab it from the queue. A report containing relevant slide imagery will be generated and sent directly to you via your preferred receiving method. Our average turnaround time is 50 minutes. We look forward to bringing solutions to your hospital and help you diagnose.
I will say, that's a pretty interesting, concept, but it's also it's pretty much exactly what a lot of the current laboratories are doing. If you look at IDEX, you look at Antech, you look at a lot of these guys, they are scanning these slides in, digitally uploading them, and then they're able to quickly send them out to various pathologists around the country, and realistically reducing a lot of their equipment costs, a lot of their pathologists in the house costs. These guys are reading these things from their house. So just like digital radiology, this digital pathology is coming, and this is not going to be something in a few years that's we're just talking about. It's going to be something just like a CBC machine that people didn't have a few years ago. It's going to end up in your place. So if you look at the expense on this, obviously probably the thing that got hung up on was you got the cost of the slides, but let's say you double the cost of the slide to the owner, $80, so they charge them $160. It's still not that far out there when you consider what you're charging right now, and it's not that far out there when you also consider you got the results in 1 hour. It's pretty astonishing. They also can, if you've got multiple sites, you're getting cheaper cost, so that's a pretty big deal. And I think in general, you're going to have scenarios where, yes, that's what I want. I need it right now, and you're going to have scenarios where you don't need it right now. But there's another option. So snapshot. So and the other thing was you had to do a minimum, right? You had to do the minimum, and you had to get their equipment. And the reason there's a minimum because they are putting a pretty significant amount of equipment in your hospital. You got that computer, you got all that stuff, you had the scanner. So snapshot is one that I want to play with a little bit. So this is just taking your current microscope, and they come in and they equip it with a little digit photography that hooks to your cell phone or to any camera. They have a unit that sits on your microscope, and basically when you're looking, you can hit a button and take pictures as you're going through your slide. So snapshot image is submitted for interpretation. It's just digital photography. Again, 1 hour turnaround time. The cost of the image or the slides is $40, and there's no minimal number of slides required for services. You simply just use it whenever you want to use it. And limitation with it is just a single image, a true slide interpretation. So you got to be the person who gets a good picture, So, but they can still zoom in on it. They can still do things with it. Obviously, it's just a different kind of technology, but they are doing that, and those, that is that guy right here on this corner, and you can see like the cell phone thing. That's what they're putting in on these machines, and then the big scanners over there. So I thought it was neat. If you go to the lacuna thing, they're the guys that are really kind of coming out right now with it. You will see more of this as soon as they get some competition. I think you're going to see this really become a bigger deal in some of these hospitals, and pretty interesting. USP 800. So USP 800, guys, is a big deal, and I'm not trying to end on a bummer, but I am trying to end on kind of a reality check here for this, and that is that starting December 1st, 2019. They're starting the deadline December 1st, 2019. It's probably realistically for the state of Tennessee going to be sometime early spring, but this is going to change chemotherapy in veterinary medicine big time. Yeah, big time. USP 800 stands for United States Pharmacopoeia, or United States Pharmacy Board, basically. And 800 is the latest kind of manifestation of guidelines for hazardous drug handling and administration. This is not a veterinary thing. This is a nationwide thing, whether you're a dentist, veterinarian, or a medical doctor. But it is a new federal enforced standards for safety in veterinary hospitals regarding hazardous drugs. It does include required personal protective equipment as well as facility standards, and that is going to be the big one, the facility standards of handling and preparation. So right now we have a chemotherapy hood that is a class B2 circulated chemotherapy hood with ventilation. We have obviously protective equipment with all the standard protective equipment, obviously gloves, but we also use a closed system. So our closed system right now is where you have a unit that goes on the bottle, unit goes in the machine, unit goes on that catheter, unit goes on your unit goes in your syringe, and it all snaps together so there's no exposure to people. This is not about the patient. This is about your staff, and that's what it's about. The current scenario is I can have my chemotherapy hood and my patient and my people and everybody in the same room. That absolutely stops come December 1st. You cannot have your chemotherapy, your hood, your people in the same room as an animal. You actually have to have a completely separate annex room built into your hospital that has external ventilation that pumps the air out of the building with separate airflow, separate air ventilation, and you have to have your hood, your closed system, and your protective equipment if you're going to handle hazardous drugs or chemotherapy in the state of Tennessee. This is your whole gamut of what you're supposed to be wearing. Whether everybody does or not, this is what you're supposed to look like when you give a dose of vincristine. But the big thing is this stuff is, this personal protective equipment is one thing. That is something where you can say, well, I'm offering all that, I have that, my staff has that ability to wear it, we push that. But this is where the things are going to change. So we've kind of pushed back on this for years and just saying, okay, is that really necessary? A couple years ago, actually a veterinarian led this. The USP 800 was actually led by a veterinarian who developed leukemia after years of giving chemotherapy, and he kind of blamed his safety standards on it. So he went in front of Congress and petitioned this. So if you think this is not going to be affecting veterinarians, you're wrong. Like this was led by a veterinarian. But they went into UC Davis Vet School and they actually stuck pads on the floor of the oncology room and pulled them off and then took them out. And literally just went in there, stuck them in, had them work for like a week, and then pulled them up, and they were soaked in chemo. I mean, they were just chemo particles all over it. So we know that these chemo particles, even with closed systems, everything are in the air. Reason I know this is there's a whole section at Veterinary Cancer Society about this, and of course we're all preparing for it. But they went in and did this, and so what they said is like, hey, when you're preparing this, you're getting it on the floor, you're getting it in the air. This is aerosolized. This stuff is out there. And these patients are at risk, or not patients, but your staff is at risk. You're at risk as a doctor. Your clients are at risk if this is being pumped through your hospital. So what they're saying now is that if you're going to handle hazardous drugs, you're going to have this, you have to have an annex room. You have to have an annex room with external airflow, and so we're actually having to build an annex room next. We're actually expanding our hospital. It come in the first year. We're going to be expanding across the parking lot here into the building here in the middle, and we're going to be building a new chemotherapy room with an annex room on it. An annex room will look something like this with a slide door, chemotherapy over here in the middle that's stored, and then your hoods and stuff. that, I'm not saying that I absolutely agree with this level of safety. I'm not saying that it's the wrong thing. I'm just saying it's the reality. And certainly, as we look at this, they have started to talk about kind of what are the implications. I would say you probably have 6 months to a year of kind of a cush. I may be wrong, but I would say that you're going to probably have a little bit of a time. But if you're not an oncologist, I think if you're an oncologist, we're not. I think they're going to come in, and when they inspect your facility, they're going to say, "Where's your annex?" Because that's the way it's going to be written. If you're going to handle chemotherapy, where I'm going with this is you need to kind of educate yourself, because I think they could start to come down and levy pretty hard on people who are handling these drugs. And I also think that one of the things that makes us vulnerable as hospital owners, as doctors in general, is you are always going to have somebody that gets disgruntled, whether it's an employee or whatever. And if they do enough research and find something like this and go, "She doesn't have that," they could be a squeaky wheel. They could call somebody up and go, "She doesn't have that." And so those kind of things they're just the world that we live in. They're going to be there. And like I said, you have to just be prepared, just like years ago when we were talking about radiology and having gowns and having gloves and protecting yourself. People are really about that safety, and I think they should be. But this is something that's happening, and so USP 800 is one of those things I wanted to just bring up, because a lot of people hadn't heard of it, and I thought it was. I think it's been kind of flying under the radar for a little bit, but it is definitely going to be going into effect next year. There's some videos and stuff on it. I'm gonna skip this video just for time's sake, but go on and watch a video or two, and it'll allow you to kind of at least get an idea of, like, am I at risk or not at risk? Because if you are handling these chemotherapy drugs, it just may not be worth it for you. It really, and I'm not saying that for any reason other than there's going to be some changes in how we do our stuff. This is veterinary business, and so as soon as I Googled, first thing that popped up, today's veterinary business, are you ready for USP 800? Clock is ticking. The implementation of guidelines designed for proper handling of hazardous drugs in oncology and other settings. This is June of 2019. This just popped out, and basically they're just saying, we're in it. We're in it. Here it is. This is the deal. And they go through the whole thing. What's done today? What are people doing right now? And it talks about kind of what we're doing. 797 was the first one. 800 is the new one. And they kind of stepped it up to these clean rooms. So these clean rooms, what I'm talking annex, and so here's what you got to do to get compliant. So here, if you want to learn more, it's out there. If you want to learn more about cows, that's out there too. So again, I'm not trying to end on a bummer. I think there are certainly still things you can do, because there are things that you don't have to have a clean room for, an annex for. Oral chemotherapies are different than injectable chemotherapies, and so there's certainly some things that when you look at it, there's certain drugs that don't fit under this. But the other thing that surprised me is I'm an oncologist, so I'm looking at this going, okay, I got to worry about chemo. Then I start reading through it, and it's not just chemo. There's other hazardous drugs that we handle on a day-to-day basis that were on that list that I was like, oh, I didn't know that was on the list. Oh, I didn't know they consider that a hazardous drug. So look it over, and yeah. So like I said, if you guys have any questions for me, I can certainly try to get you some information as well. There are some really good brochures, some things they put out every few months about it. I'm getting in the mail, and so you guys can certainly give me a call if you have any questions. Thank you for coming tonight. I hope you got something out of it. Does anybody have any questions whatsoever for me? If you do, I'm happy to take them now. If you want to talk to me after, I'll stick around for a little bit. Thank you, guys.